In this recording, we're going to continue our discussion of coding of burns and corrosions, Part 2. Next guideline, assign separate codes for each burn site. This guideline is telling us that even though there is a classification for body region unspecified, it's a very vague term. We really don't want to use that unless it absolutely is our last recourse. It's better to have multiple burn codes that cover all these sites instead of having this vague T30 code. In this diagnostic statement, the patient is a food service employee who sustained first and second degree burns, thumb and 2 fingers on his right hand, and a second degree burn of his right forearm from a kitchen fire in the nursing home where he works as a cook. This is the initial encounter. Obviously, you've got several external cause codes. There are 4 actually in this case. And I built it this way on purpose, so that you had to use those external cause codes. There is a code, T23, for a burn of a finger multiple sites, because in this case our diagnostic statement tells us it was first degree and second degree thumb and 2 fingers. Remember from an earlier guideline we were told we only code the higher degree burn. So even though he sustained first and second degree burns, multiple sites on his right hand, we're only going to code the second degree burn. Then we code the second degree burn of the forearm. Then we get into those external cause codes. Exposure to the fire, the activity he was cooking, he was working, so we're going to use that Y99.0 code. And last of all, it gives us the place of occurrence. In case you're wondering why all these codes are collected like this, many times it's public health keeps records of all of these ways that people get hurt. Also, insurance companies keep them, looking at their risk analysis, how many people actually get burned working around fire and have to get workers' comp. So they look at those things. So there's many reasons why statistics are kept. So it's important that we are coding the correct things, because people beyond us, the secondary users past the hospital, secondary users are going to be looking at these codes. The next guideline has to do with the extent of body surface. So I'm going to go through this. I'm going to show you some pictures and see if we can't get our heads wrapped around the rule of 9s. T31 are your burns and T32 are your corrosions, but both of them use the extent of body surface involved. There's something called a classic rule of 9s that estimates how much body surface is involved. And I break it down here by the percentage of how that's looked at. But a provider can change those percentages depending on how the physician is the provider. The physician is interpreting the burn. So in other words, if a patient is an infant, they have larger heads than adults. So they may give the head and the neck a higher percentage than 9. Also, a patient can be very large, really overweight person and have really large buttocks, thighs, abdomen, trunk. So the doctor is going to change the percentage. So it may not always be the classic rule of 9s. You really have to read your documentation to see how the physician is determining the body extent. I pulled some images off of Google Images to show you how the rule of 9 might be looked at. The adult on the left, the infant on the right, and see how the differences in those percentages work out. I also pulled off this from Google Images that shows you how when you read that the trunk is 18%, this image on the left actually breaks up the top of the trunk as 9% and below the diaphragm. The diaphragm is your dividing point between your upper and lower trunk, and also upper and lower back. So you see how they get that. Okay, let's go to the next guideline. The patient sustained first, second, and third degree burns over his body. 10% first degree, 15% second degree, and 32% over the trunk, third degree. The patient is a crew member of a ferry boat steamship on which the boiler exploded. Whenever you see a physician giving you the extent of the body surface involved, and you're going to be looking for codes that help you code that diagnostic statement, first thing you're going to do is add up these body surface areas that he or she has given you 10% first degree, 15% second degree, 32% third degree. 10 plus 15 plus 32 gives you 57%. 57% of this patient's body has some type of burn. So when you actually start coding it, we're going to code the third degree burn to the trunk, and then going to code the extent of body surface area. So I have the pathway here on the right that you can follow along and see how I'm getting that. I'm choosing the range that contains 57%, which in this case is 50 to 59%, with 30 to 39% third degree burns. So it really is how your classification is built. You really need to go to your code book. I can't show you this really. My document camera is not working right now. But if you go to your code book and you look under burns unspecified site with the extent of body surface involved specified, you start with that percentage that we added up here for extent of body surface involved, and then look at the burns on third degree, and that would be your trunk. Then the next three codes are external cause codes. If you ask me, why didn't you code the first and second degree? Well, if you look at the diagnostic statement, it didn't give me anything to code. So I would only code the third degree. The next guideline has to do with encounters for sequela. Sequela for burns typically is scarring, or you can have contractures at the joint, or you can have a scar that is so fibrous and condensed that it just pulls someone's skin together so that they can't extend their arm or their leg, whatever's burned, because of that scarring. So this patient is being admitted for release of skin contracture due to third degree burns of the right hand that occurred in a house fire 5 years ago. Automatically, when you're looking at something 5 years ago, you know you're looking at a sequela. A skin contracture is a sequela of a burn. Skin or joint contractures are both sequela. And whenever you're looking at a sequela, it's the seventh character of S. The contraction, the scar contraction in the alphabetical index takes you to cicatrix, and then that gives you your scar. And you could also look up scar. Either way, you get that L in 90.5 as your principal, because the patient is admitted for release of skin contracture. That's your principal. Then you're going to code the third degree burn of the right hand with the seventh character S, and then the exposure to the fire. That's your X code. Per the coding guideline, back in A, the specific type of sequela is sequenced first, followed by the injury code. So in this case, we're coding a release of skin contracture. Your skin contracture is your sequela. That's going to be coded first. Then your burn, then your external cause. For those cases when you have both a late effect of a burn, an old burn in other words, and a current burn, both the code for the current burn using a seventh character A or D, depending on if you're in the routine healing phase or you're still doing active treatment, and a burn with a seventh character of S for sequela can be assigned on the same record when both exist. Burns and corrosions do not heal at the same rate, and a current healing wound may still exist with sequela of a burn that's already healed. In the diagnostic statement, the female patient is seen for second-degree burn to her left ear, and she also has significant scarring on her left elbow from a third-degree burn in her childhood. So this patient has both initial encounter for the burn to her left ear and also the scarring for the sequela code. So whenever you have a sequela code, you're going to put whatever the sequela is, in this case the scar, and then the burn that caused the scar. Sequencing is really important. I think it's some of the hardest things for us to learn. But if we read our statements, read the way the doctor says it, and follow the guidelines that step you through how to do it, it isn't as hard as it seems. You just can't get away from going back to those guidelines for direction of how you would sequence codes. The use of an external cause code with burns and corrosions is something we've been doing all along in all of our examples. I'm just showing you that there is a guideline that tells us we have to do that. But the diagnostic statement I've chosen is something a little bit different, and I did this because I wanted you to know that sometimes a burn may not be in the burn chapter, chapter 19, especially when you're talking about eyes. The patient sustained a bilateral corneal flash burn due to a welding torch. A corneal flash burn is really photokeratitis. It's one of those many terms I'm sure you have noticed as you've moved through the semester. Sometimes a medical term already exists that explains something that the doctor says another way. So we have to recognize what the doctor has said, understand how that is described in the ICD-10 book, and then go to the ICD-10 book with what we know to be the way the code book recognizes it and look for that code. So if you're reading a chart and it says the patient sustained a bilateral corneal flash burn, you're going to remember a corneal flash burn is photokeratitis. Snow blindness is another photokeratitis diagnosis. Photokeratitis takes us to H16.13, and the 3 as our 6th character says it's bilateral. And then the radiation, there is a specific code. I had to look for this. I knew there was a code for welding torch, but couldn't think of, I was looking under burn and another one and couldn't find it, so I just kept looking because I knew it was there. It's under irradiation. So again, one of those things we have to remember when we're looking at welding torches, the burn that results from a welding torch is radiation, not burn or injury. Does that make any sense? That's all we're going to talk about for burns and corrosions, and I'll be continuing our discussion of Chapter 19 in more of the future podcast. Thank you and have a good day.